It is such a pleasure to be able to introduce our closing keynote speaker, who is the second recipient today of the Rice 360 Innovation and Leadership Award. And I'm very pleased to introduce Dr. Patty Garcia. She's receiving this award in recognition of the many contributions that she has made to improving global health equity in Peru and around the world. Dr. Garcia is a professor of public health at UPCH in Lima, Peru. She's a medical doctor. She graduated with her medical degree in Peru, and then she went to the University of Miami for training in internal medicine and the University of Washington for training in infectious disease. She has a master's and a PhD in public health. She has government experience. She is the former Minister of Health from Peru. She also served as chief of the Peruvian NIH. Her achievements have been recognized with election to the US National Academy of Medicine. I first met her when we both served on an advisory board at the University of Washington. And then we also both had grants through a program that was funded by the Gates Foundation, and we would get together regularly as a whole program. And the thing that always struck me about Dr. Garcia is the way that she approaches big problems in global health by bringing a real spirit of optimism, creativity, and practicality to get the job done and make sure that people have access to better healthcare. So to our audience, I think you are in for a real treat. And to Dr. Garcia, congratulations. We're really delighted that you're here to present our closing keynote. Please join me in welcoming Dr. Garcia.
This has been a very intense but also energetic day, and it's so great to see so many young people interested in global health. So you really give me hope and give us all hope that things are going to move in the right direction, although we see all the kind of things that are happening in the world. So thank you so much, because that is already a treat. So I was invited here to share a little bit about my career, okay? And so as you have heard, I was born in Peru, and actually I work in Peru, but I travel quite a bit. And one of the things that I convince is the most important thing that we can do in our life is to leave some legacy. And the most important legacy are people. So the people that we train, the people that we work with. And so I hope that you're very young, but you're going to start doing that. So let me start, if this works, to talk a little bit about my life in health, research, and innovation. Okay, so this is me. As far as I know, and as far as I can remember, I've always thought of myself like a curious person, a thinker, looking for ways to improve things. And here, this is me at 4 months old. So, and I was always pondering the questions of life, like you can see here. But as I grew up, I learned to read, I learned to write, and most importantly, I learned to look for answers. So I was there, sitting in my father's desk, and always with a passion for learning. So the question is, how did I really channel all of this into my actual career? And there is one thing that you have to remember: there are always defining moments in life. And one of the moments that defined my life was when I was around 7 years old. So I got really, really sick, and I ended up in the hospital. So the doctors thought that I was having a hematological malignancy because my liver and my spleen were very big. And it took a long time for them to realize that it was not the cancer of my blood, that it was an infectious disease that was very common at that time in Peru. It's called brucellosis, and you get it from cheese, goat cheese that is contaminated. So actually, I was very scared because the doctors were telling me that I couldn't move because my liver was really big and my spleen was too. However, they came every day and several times a day and talked to me, and they make me feel comfortable and they make me feel safe. So eventually I received the treatment. I had to stay in bed for almost a year. Thanks God I didn't lose school. But one of the things that happened is that I took my first big decision. I decided to become a doctor so that I could save lives, just like the doctors that saved mine. So, of course, I wasn't always completely sure that I wanted to become a doctor. For a while, I thought that I might be a guitarist or a dancer or even a supermodel, you know. But at the end of the day, I knew that the best thing that I could do was to become a superhero, and which is exactly what people working in public health and global health are. Even though back then I had no idea what public health was, I knew that I wanted to be a good doctor and I wanted to work doing good things. So I finished a high school and got into medical school. And back then, in my school, there were only 60 people, and we were 8 women in my class. So you can see all the women in my class. And I studied, and eventually, I met my now husband, who is on the left side, and Cesar, and finally I graduated. So you can see there my sister in yellow, my father, and on my right side, my mother. Everybody was happy, very happy. I was very happy because finally I was able to fulfill my dream that was to be a doctor. However, again, things may happen in your life. I never thought about coming to the US. Actually, I was not able to speak English, really. But my dad was diagnosed of lung cancer. You can see that he was losing weight already. He was a smoker, unfortunately. He was also a journalist. And this was another defining moment. In order for him to get the treatment that he needed, I needed to, and this is one of my professors told me, probably the only way to save him was to take him to the States. So I decided to accept an offer to do my residency in internal medicine abroad. Unfortunately, my dad died just a few days before my trip to the US. But I have already signed the contract. I have to maintain my mother and my sister. And I still wanted to be a clinician. So I came to the States and I fought, I learned English, and I wanted to be an ID doctor, to see patients and cure them, or at least try to. But everything changed really in my life by the time I was already in the States and I met somebody. I met this person that you see here, is Dr. King Holmes, the world expert on sexually transmitted diseases. This was yet another defining moment. He convinced my husband, not me, okay? I was very pissed because I actually applied to the University of Washington to do my infectious diseases fellowship. And I received a letter that said that they didn't accept foreigners. Okay, so I accepted to go to Emory. But actually, somehow he saw my CV, he liked it, he wanted to work in Peru. And so finally, I ended up working at the University of Washington. And although I wanted to be a clinician, he convinced me to enter the Master's in Public Health. Do it just for fun, he said. And so King really taught me that the best way to help people is probably through public health. Because you can help thousands, you can help millions of people at one time. If you do one thing in the right direction, you can help thousands of people. And he became my mentor. I started working in different projects. I saw the light because I realized that with good research, you can answer questions that can change the lives of people. And I was able to meet incredible people around the world and start working in global health. King just passed about a few weeks ago, but I think that he really touched the lives of a lot of people. It definitely touched my life and changed my life and the life of my children, my students, and my grandstudents, because you have the students and all the other generations, and I think he made a big change. And actually, he made me see the light, and that's the truth. So in the meantime, while I was doing all this research, I got married with my husband, Cesar, that you see there, and I had my two wonderful kids, Paloma and Marco. So Marco is the big one that is sitting on my lap, and he's very happy because I gave him the gift of his sister. And Paloma is that little one that looked like a potato wrapped in a blanket. And so nowadays, they are all grown up, and both are doctors. So Paloma is doing a doctoral degree in epidemiology. She's doing math modeling. And Marco is in his residency for pediatrics. And they are very happy, and I am very happy. So that's kind of my story from the point of view of my life. But so now let me tell you a little bit about my projects and what have I done in my life. So when I started to work with King, one of the things that he asked me, because he worked on sexually transmitted diseases every time, the first time I met him, he said, like, you know what is my passion? I said, like, no, sex. And I got so scared, but said, sexually transmitted infections. I said, what's that, right? And so, like, have you ever been trained on sexually transmitted diseases? And actually, when I was in medical school, nobody talked to me about that. So the question was, so where do people with STDs go in Peru? When I asked my professors, they were telling me, you know what, those are diseases of the developed world. Like nobody was having sex in Peru. And actually we knew that they were having. And the question is, where are they going? Was a really true important question. And that's how I started working on STIs in Peru, asking the question, gosh, where do people with STIs go, right? And actually, I decided, I was really pondering about what happened, and I had to take a taxi, right? And the taxi saw me and said, like, what is bothering you? And I said, like, you know, I have this question. Where do people with STDs go? And he said, because taxi drivers are wise men. They know, they really know. And they told me, of course, that's an easy thing. They go to the pharmacies, you know? And they go to the pharmacies because they come in different colors and forms. And they are always open and they are never judgmental, okay? So that's how I started, first of all, working, not at the hospital or a clinic. I started working with pharmacies in Peru to understand what was happening with sexually transmitted infections in Peru. And actually, we started, first of all, we documented that there were STIs in Peru, looking at the health certificates that people had to get in order to start working. So the data was there, but nobody had analyzed it. So we did have chlamydia, gonorrhea, syphilis, and it was documented, but nobody was seeing it. Then we started to go to pharmacies and try to see if people was going with symptoms, and they did. Then we tried to see how the pharmacies were working, and actually it was like they were working and seeing patients with STDs, and they were learning how to manage them for the prescriptions of the physicians that sometimes were coming to them. And we also were able to measure the prevalence of STDs in clients of STDs, of pharmacies, and those prevalences were similar to the ones that you could see in other countries at clinics or any hospitals. So there were STDs in Peru, and that was a big surprise for everybody. So, ta-ta-tang, the other thing that we were able to do is we quantify the impact to work with pharmacies and STIs. And we realized that for one patient with a sexually transmitted infection that was seen at the Ministry of Health clinics, so once in a while, there were about 10 seen by private physicians and about 100 seen at pharmacies and boticas. Boticas are like pharmacies, but they are like more open. They can be selling other things also. So that's how I started working and showing what STIs were. So from there, we had the idea, okay, so now that we know that people are going there, what can we do to improve what's going on? So we decided that it could be a good idea to do a community randomized trial with a hybrid intervention, a mixed intervention to prevent STIs. So the idea was, why don't we train the pharmacists and the clinicians, okay, on strengthened STD syndromic management? And then why there are groups in the population that have higher risks, and one of those groups are commercial sex workers. So why don't we work also on those high-risk groups? And the third is, why don't we really involve the community and start doing some social marketing of condoms and casual and commercial sex, and have a health communication campaign so the population can be empowered and understand what sexually transmitted diseases are. Because before that, nobody knew about, not even my professors believed that there were STIs. So we decided that we were going to do this huge trial, and we were lucky to get funding from Wellcome Trust. The idea, and this was a huge thing, 20 cities in Peru. Peru is a country with about 30 million people. So 20 cities, medium-sized cities, between 50,000 to 300,000 inhabitants. The idea was to do a baseline survey, door to door, with young population, taking samples, getting prevalence of STIs and also behaviors, and then dividing these cities in intervention and control. In the control, the same thing, and the intervention, the 3 interventions. And after 2 years of intervention, do again an impact evaluation with another survey. This is a huge thing. We're talking about more than 100,000 participants, 20 cities, and 5 years total. And we did it. And the interesting thing is that we showed that there was an impact of the intervention on the prevalence of STIs, on female sex workers, and on the women in the general population. And actually, this has been published in The Lancet, and we also work together with the government to implement these actions, and this has been a model for other Latin American countries. So this happened around 2010, 11, okay? So some time ago. And around that time, I was offered to become the head of the National Institute of Health of Peru. And actually, this is an institution that has more than 120 years now, and there has never been a woman. And they have to change the name of jefe, which is chief in male, right, to jefa, and there has to be almost a presidential resolution for that. It was a great experience because, sometimes we really talk about what the government is doing, but there are also limitations for the government of things that they could do. So I think this jumping from academia and researcher into the government taught me lots of things about the limitations and how it is quite important to create bridges with the government in order to be able to work together and make things happen. So there were several things that I did during that time, but one important thing, in my mind, is that I could realize, all the challenges that I have seen from the research side, from the governmental side. So most of the countries, low middle-income countries nowadays, we are dealing with this double burden of diseases. So we still have all the infectious diseases that are hitting us very hard. Like you can see, in Peru, 1 out of 100 women are still having syphilis. And syphilis is much more common than HIV in Peru. And if you see what happened with women that are having miscarriages, the rates of syphilis in those women are much, much higher. we have anemia, and the other thing is that tuberculosis. 1 out of 3 Peruvians are infected with tuberculosis. So that's very high. That doesn't mean that they have the disease yet, but the risk is there. But on the other hand, every 5 hours, a woman dies from cervical cancer, which is a chronic disease. And we have now 1 out of 10 people with diabetes, and 1 out of 5 have high blood pressure. So we still have lots of things that we need to deal with. So, and the other thing that I realized working at the National Institute of Health is that compared with what other countries were doing, we were very behind in several things in health. So the 21st century has definitely new players that bring challenges and bring advantages. And those 2 important players are, 1, communication technologies, the internet and the mobile devices, which could spread ignorance, prejudice, and superstition, but can also provide information and knowledge and can improve the reach out. Because even, and this is something that is also very common in low middle income countries, is that the use of cell phones and the penetration of cell phones is very high. And at least in my country, even in rural areas, people will have a cell phone because that allows them to connect with the modern world. And the other, and this made me think, going back from the National Institute of Health into academia, there is a need to create capacities in Peru on health informatics. We never had a program on health informatics before that, and we are about 2012, okay? And the other thing is that science and new technologies and new diagnostics were coming out. However, they were not necessarily addressing the problems that we had in our countries. And sometimes they are too complex, they are costly, and they can bring new environmental and biological risks. And I want you to think, since you are developers, you're thinking about developing, think about when you design something that whatever it is, it shouldn't be another thing that damages our environment. And we have to think about the waste, and we have to think about how can we produce new technology that will not damage the environment. We need less waste, no more. So these are great solutions, but we need to start thinking about point-of-care diagnostics, diagnostics that can be used by the provider in front of the patient, or diagnostics that can empower the population to do their self-testing, for example. So after being at the National Institute of Health, I changed and I said, like, well, sexually transmitted diseases are quite important, but let's start thinking about these other umbrella things because we need to create capacities. So I was able to get a grant from the National Institute of Health, and we started this huge program called KIPU. KIPU is a system that the ancient Incas had with the strings and knots and colors to communicate and also to count, okay? And so we started this health informatics program. First, it was a certificate, a master's, and we trained people from all the Andean region and in Peru. And this was the first master's degree. It has been institutionalized. And actually, most of the people that are working now around the country had been trained in this program. And we created also a very big program for research, starting from telemedicine, mobile health, different projects with cell phones, electronic medical records, and internet-based interventions. And actually, the work that we have done on electronic medical records, it's something that I eventually used when I became Minister of Health, and we started the law for electronic medical records, and we started the introduction of electronic medical records in Peru. So regarding point-of-care diagnostics, that's when we had the opportunity, because we had the funding from the Gates Foundation. Initially, the fund that we got had to do with understanding the ecosystem for the introduction of technologies in low middle-income countries. But then WHO contacted us because they were quite interested. They have a relatively simple test to diagnose syphilis. It was very cheap, but nobody was using it. So the idea was, how could this test that has proved to be simple, cheap, and very effective, actually is a confirmatory test for syphilis, could be implemented in the countries. And so, partnering with other countries, we started a multi-country study. In Peru, the study was called CISNE. CISNE is a Spanish word for swan. And actually, this name was given by the women that were part of the study when we were telling them about syphilis, that is a disease that can kill the baby. But if you are diagnosed early and you receive the shot, the baby will be beautiful. So one woman said, this is like the ugly duckling. If you receive the treatment, it will become a swan. So it became very popular. And the idea with this study was, let's see how can we work on the implementation. So in a relatively short time, because it was about a year, because Gates wanted to stop the study and retrieve the funding, we convinced them not to do that. We were able to prove that using this rapid test in the hands of the midwife seeing the patients and empowering the women to see also the results in the same office, we were able to increase the coverage of screening. But not only that, you know, before we started the study, we rediscovered, okay, that when women was going to the first antenatal care visit, everything was so fragmented and so chaotic that they had to come additional times, almost 6 times to complete her first appointment, and several times once they had the test, the treatment was not available. And although we had, for example, the rapid HIV test, the rapid HIV test was done at the laboratory by the technicians because they felt that the power was theirs. So when we started to understand what the technicians think, what the women think, what the midwives were thinking, what the pharmacists were thinking, what the guy that was watching the door was thinking, what the women were thinking, everybody, then we designed a system that allowed us to move from these almost 27 days, and several times the treatment was not completed, to a much simpler system. This was very complicated, as I said, to a much simpler system in which with only one visit, one finger stick, 2 tests, okay, the women can receive the treatment in 1 day and it could be completed. But it was a matter of using the technology as a catalyzer for changes and improvements. So it was not the technology alone, it was understanding the whole system. And I think that's another concept. Technologies can be used as catalyzers for improvements. So here it is, and in 2011, this rapid syphilis test became national policy. And actually, you in the US, I don't think you have approved of the rapid syphilis test. We have been using it since 2011, and that helped to really decrease the rates of syphilis. So this was another project that was funded through Grand Challenges Canada and the Gates Foundation, and that was kind of like the follow-up. Once we understand the ecosystem, how can we develop models for enhancement and rapid uptake of technology and point-of-care tests? So we had basically 2 models. One model had to do with the pharmacies, right? So pharmacies are where people can go easily. They don't need to have appointments. So what the client has complaints, the pharmacy worker can offer products, okay, but can give counseling also. And if everything works well, they can refer the people that needs to be referred. And so we decided to work on a model for non-communicable diseases like diabetes, also to anemia, and another model for tuberculosis. And actually, it was quite interesting again. The user's perspective is critical. So we work a lot with pharmacy workers to understand what were their motivations, what could they do in real situations, what works, what doesn't. And this is, for example, this is Camila. Camila is working at one of the, it's a pharmacy in Lima. And actually, she had created this corner where now she is using different technologies, okay? And she's testing for glucose and for anemia for the clients that come, and then she offers referrals, etc. So this could be, it's possible. And in the model for tuberculosis, we also explore what happens in the pharmacies with tuberculosis. And actually people, when they have cough, the first place they go is to a pharmacy. In order to be considered a respiratory risk, somebody has to be coughing for 2 weeks. But several times they come to the hospitals after months, okay? So pharmacies are willing to use technology and to help to identify the people for the first screening and then create a referral. And now we're working with the Ministry of Health to see how we can create this type of model. So another model, I talk about pharmacies, is the model of how can we empower the community. And one model that we have been working, I'm still working on, is this that is called HOPE, okay? HPV self-screening to improve women's life. We started doing in 2015 a feasibility study, a proof of concept study with Grand Challenges funding. And actually, this was quite interesting. The idea is that we know that in Peru, every 5 hours a woman dies from cervical cancer. But we know also that HPV is the virus that causes cervical cancer. If we can identify who are the women that are infected with HPV and that their body is not able to get rid of HPV, and so those women are usually women over 30 years old that are positive for an HPV test, those women can be our focus, and we can work on them to try to give them, so that's a better screening because it's even before they develop cancer. And we can decrease the risk and we can have healthier women. And so, but what we decided in this model is to work with the community women, identify women from the community that are willing to work with other women, train them to understand what cervical cancer is, HPV, self-sampling, and be the first ones to have their testing. So these women decided to call themselves the Hope Ladies, okay? And they started working, promoting in their community self-sampling with a vaginal swab, which is a relatively simple thing at home. Then we work with health centers, so they could have these kind of like mailboxes open 24/7, where women can deposit their sample. The good thing is that nowadays, the molecular tests are very stable, so you don't need to refrigerate or anything. So it can be left there. And then we have these motorcycles that will collect the samples twice a week, bring it to the laboratory. We had one central laboratory. The technology is relatively simple. It's only 3 hours in general. We were giving the results through self-messages, okay? SMS messages, and all the women that were positive had to come to the health center to be treated, and the result was healthier women, early detection, and better prognosis. We call this our new cervical cancer screening model, HOPE. Actually, we got funding to do this on 500 women, but it was so popular that I was able to get a donation, so we eventually include more than 2,000 women. These are the HOPE ladies that are really the champions here, okay? And what did we learn? Well, we learned several things. The first one, and I have to tell you this, is that the community can help you on the science. And actually, we did something. When we were working with the women, we were asking them, how can we reach the women to be able to give them the sampling, the kits, right? And actually say like, well, the best way is to find them at the markets, because the women will leave the kids at the school and then they will go to the market, buy, and then they will be cooking, right? So how can we do that? And so one woman said like, I wish we could have like a bag where we can put everything that then we can show them how they look from their inside. And they start designing things while we were talking. So eventually, we got this. The whole bag. So the women will have inside here the materials they need, which is basically the tube and the swab and some other materials. But the most interesting thing is that they will go to the market, and when they found the women, they will say like, do you know how do you look from the inside? And most of the women don't know that they have, all the different holes that they have, where they can put the swab, and how this will go. And this became a really incredible innovation, okay, simple innovation that allowed us to really reach more women. So you can see in the other picture, you saw all the women, we had it in blue color and we have it in green color also. But this is how you can co-design with the community. So we were able to reach more than 2,100 women. 2/3 of those women never had a pap smear before. And so we really improved the coverage for the screening. The women love self-sampling and learning from other women. These collection sites that were available and open 24 hours, 7 days a week, were also very important. In general, people really love technology, okay? And they appreciate technology, new tests, use of cell phones. But the challenge was, okay, once you have somebody who is positive, you cannot step there. That woman needs to be seen and needs to be treated. And so the question that remained was how to ensure that every positive woman receives treatment and follow-up. Plus, would it be possible to reach even more vulnerable women? Because we work this in the coastal part of Peru. Peru has 3 regions, the coast, the Andes, and the jungle. So we did it in the coast. Can Andean women do this type of test? Can we really reach them, or women from the jungle? So by that time, I was already finishing my time as Dean of the School of Public Health, and I was called. I'm not a politician, okay? I never knew the president or anything, but I received a phone call on a Sunday, so like if I was Dr. Garcia. I thought it was a joke from my colleagues, but actually it was the recently elected president, and he called me, we talked. He was looking for somebody to do public health, and as you can see, I became Minister of Health. I was very happy. It was the most stressful time of my life, but I'm happy that I tripled the average time of any Minister of Health in Peru, and I was able to do several things that have lasted. And one of the things is that I implemented in the country the self-sampling and the HPV molecular testing. We started it, but then the next of the, well, has been in 2016 and 17. Since 2017, there have been 15 ministers of health in the country. And just last year, and so I was very frustrated, so I did what I know how to do. I started, once I finished being minister, I started writing grants. So my vision was we need to redesign care delivery from hospitals to communities. And everybody talks about people-centered management, right? So that means that we need to go closer to people. So with the idea of the cell sampling, we are getting closer to the community, but we still need to get closer for the treatment. And most of the treatments for cervical cancer are done in the hospital. So how could we change this paradigm of sending everybody to the hospital, and instead of that, using technology to bring the solutions closer to the people, maybe to the primary health level? And I was very lucky when I was doing a presentation about that at the Consortium of Universities of Global Health that I met Nimi Ramunajan. And Nimi was having one technology that was quite interesting. That was a pocket colposcope. A colposcope is a little machine that can, well, it's a huge machine, very expensive, that can allow you to see the cervix and see if there is any lesion. But it's very expensive. Nimi was working on a pocket one that also could be connected in real time. So we started working together, and we decided to write this grant to work HOPE, but in the Andean region. So we call it HOPE Cajamarca, in collaboration with Duke, and we got funding from USAID. So basically, we decided to close the gap between screening and treatment for cervical cancer in Peru, using new technologies and using them as catalyzers for redesigning systems. Okay? Again, what I do is I don't create technology, but I think technology has the power of helping us, waking up people and showing them that things can be done better and we can really change and redesign systems. So the idea was, okay, so let's use the self-sampling at the community level, but once the woman is positive, let's use this little thing, this pocket colposcope, to improve the way we manage, so we can see the cervix. We call it improved visual inspection, okay? With an app that is called Kala, that allows us another thing that is important. I think you heard from one of the presentations, my country, and I think several countries in Latin America were very centralized, which means that we have the capital city, Lima, has 1/3 of the population of Peru. So it's a city of 10 million people. And the rest of the country is very dispersed. So we don't have enough doctors or enough OBGYNs. So this pocket colposcope that is connected allowed us to have somebody in Lima, okay, that could in real time see the images and discuss with the midwife through the phone what the images or the cervix is having and what could be the treatment the patient needs. So we call that a tele-VIA, so tele-visual inspection with an expert on the other side. And the other thing at that time, also, there was this new device that WHO has just recently recommended, the thermocoagulator, which can treat, if there is a lesion, we can treat it immediately, and it can be treated at the primary care level. But if the lesion is too big or cannot be addressed very well, the patient can be referred to another level of the health system. But what we are doing is we're trying to treat most of the people closer to where they live. So this is what we decided to do and assure adequate management. So working with the local government of Cajamarca, we work on this redesign with the idea of trying to treat everybody, screen everybody in the community with community health workers, treating most of the people at the primary level, and then just referring those who need it. So we did this trial with 4,000 women who self-collected their samples. We found that we have a high rate of HPV of about 14.3%. 97% of the women that were positive went to their appointment at the primary health clinic. And actually, we were working everything within the Ministry of Health, okay? 78% of all the women could be treated at the primary care level, okay? So most of them were treated, sent to the hospital, and never got appointments. Here, 78% were treated within 1 month at the primary care level. And there we had some referrals to the second level, where we had 1 OBGYN, when were more difficult, and 4% were advanced diseases that had to go to the third level. So basically, you have that pyramid. Most of the people at the community and most close to the community, okay? So at the end, 87% of all the women with HPV was managed accordingly, okay? Within Cajamarca. And now Cajamarca, this region is taking the next step, and we're working with them. Unfortunately, our grant ended, and we were supposed to have another grant that was coming, but because of the issues that happened, we don't have any more money. So, but the Cajamarca government is committed to try to keep working, and we are at least advising at the distance so they can continue the scale up. But these are the kind of things that you can do. One of the things that we learn is that by using technologies, we can ensure empowerment of women, competence, because we even have the images of the cervix, and we are using those to train other professionals and for quality control. So we can assure that the management is the correct one. Integration, we're promoting integration in the system, continuity, and completeness of care, which are things that are critical nowadays, especially when we talk about non-communicable diseases. And one important thing, equity. So even in Andean rural areas, women are concerned about their health. Women are able to take their own sample. Men physicians thought that they were not, but they are, okay? And so we can reach almost any women with this type of technologies. So I just gave you some examples of the kind of things that I have been doing, but I have a final message for you, okay? So health in the 21st century, this century that you are living, okay, it's complicated. Like when you put in the Facebook, complicated, so your relation with the 21st century is complicated. And it's complicated because there are demographic changes. We are too many, and we're getting old, okay? So you have a lot of old people and too many people. And that means that we are dealing with diseases that we didn't have before, like chronic diseases. So we have this epidemiological transition from infectious diseases to chronic diseases, but several of our countries are having both of them. And it's not that we have more money, more time, or more resources. It's more complicated to deal with these things. So we need to use technology. But not only that, we have new emerging and re-emerging infectious diseases, and we have pandemics. And we have, additionally to that, climate change that worsen health and worsen our responses and requires more resilient health systems. We have humanitarian crises that could be associated with these climate changes, with the fact that we are too many and we're fighting with each other. So we have humanitarian crises, and everything is causing other problems like mental issues. And mental issues are the problems that are considered to be the biggest burden in the world. In a world that is interconnected, which is good, but could be bad also, because now we can also not only share, but we can have contagious bad habits around the world, okay? So we call it non-communicable diseases, but the habits could be really communicable, and that put us all at risk. And a disease can go from one place in the world to the other in a matter of hours. And you know, that's what happened with COVID. And in this interconnected world in which we have social pressure because people knows what they want, and we have also technological pressure. And technological pressure because there are lots of things that are coming out, but not all the things that are brought into the market or into the light do what they are supposed to do. That's why it's so important for you also to take into consideration measuring, okay? Being sure that you test and the technology does what you in your heart wants the technology to do. So, and we have technologies that are too expensive. So that's another thing that is very problematic. So this is not easy. And in order to address all these things, we need to adapt. The health system needs to adapt, and we need to use, in a smart way, technologies and the resources that we have that are the human resources. So my research career has taught me that effective responses in public and global health require definitely innovation and significant shifts from traditional public health approaches. Research must be needs-driven. So if you're gonna do something for global health or for a country, you need to know what are the needs in that country. And it has to be rooted in real-world challenges. Collaboration and partnership are essential to achieve meaningful impact. And I hope that you create some networks also while you are here, because that's quite important. And research findings should inform policy to maximize public health outcomes. So knowing is not enough. We must apply. And that's why implementation is critical. And willing is not enough. We must do. So thank you very much. And I really think, I just want to say that all of you are already champions here. And I hope that you continue this line of doing research and be devoted to global health. Thank you so much.
I was just wondering if you had any information about the availability and distribution of HPV vaccines and how that relates to screening cervical cancer.
Oh, yeah. So we started working on HPV vaccines around 2010 in Peru, okay? And we started the distribution in the country, and then we had a back because of some anti-vaccine groups. But then it was restarted. So actually, we have, as a country, because we have pushed very hard, we have gone far on the introduction of the vaccine. So nowadays, what we have is we are using, so we went from 3 doses, then we changed to 2 doses. Now we're using the 1 dose for girls that are in school. And just last year, or 2 years ago, we started vaccinating boys also. In 2017, when I was Minister of Health, we were able to do a catch-up on girls at that point. And we also were able to do like a contest between, we have 23 regions in Peru, a contest between regions, which is something that is quite interesting because the only thing that we gave the different regions were certificates made of silver paper and gold paper and copper paper, right? But we were able to reach very high rates and coverage, so over 85%. And almost in some of the countries, 95%. So there is good acceptance of vaccines. One thing that really dropped the coverage was the COVID problem that stopped everything. But in general, vaccines had been there. But remember, vaccines are important because it will protect the women from the future. But we have still this gap of the women that have been infected, okay? And it's quite expensive still. I think we have done a lot by vaccinating girls and now boys. So we have used the opportunity of decreasing the number of doses that was initially 3, and we have already the budget set up for that. So it was possible to do catch-up and to add boys, decreasing the number of doses, right? But doing the catch-up for women that are older could help, but it's expensive. But by that time, several women would have been infected already. So that's why you need to have the vaccines and you need to have the screening. Plus, remember that the vaccine, it's going towards, we have the tetravalent vaccine. We don't have the nonavalent vaccine. So we still have a number of strains of HPV that are not covered. So we still need to see what's going on, and we need to treat the women. One thing that we have been promoting is something that we call in the country the queen and the princess, right? So the queen is the mom that needs to have screen, and the princess is her daughter. We should add the prince also. So the daughter or the son that needs to have the vaccine. I think it's important to see this almost like a family way of prevention.
I was wondering, can you expand more, like, what's like the difference between the role of a pharmacy in like Peru versus kind of what we have in the U.S.? Because I just want to know. But also, is there like, do you think there's a lot of value in like possibly increasing the amount of like at least schooling for pharmacists so that way they can possibly like diagnose and help patients more?
Here in the U.S., I think here in the U.S., one advantage that you have with pharmacies is that you can go to a pharmacy and get vaccinated. So that's something that doesn't happen in Peru, for example, okay? And so we have to go to the health center to get vaccinated. So I think you have more availability and although in Peru and in most of South America, thanks to the work that PAHO, that the Pan American Health Organization has done, the acceptance for vaccine is very high. So people are willing to suffer waiting at the health center to be vaccinated. Here you have easy things. So what I think, I don't know how medical school is here. I think you have a much better curriculum here because the pharmacist, for example, here is part of a multidisciplinary team. Each of the people had a job, like, I mean, I remember when I was an ID fellow, we were doing rounds with the pharmacy. So I will know about the drug that needs to be given, but the pharmacy will give the recommendations about biodisponibility, for example, or things like that. So what I think is that we need to think about health systems in a very broad way. So people are part of the solutions for health. So that's why we have to involve the community. And we have to involve also the pharmacies because they are part of the community and they have a role, okay? So maybe as part of the training, they need to know what is their role. I don't think the role is to diagnose, but to recognize the same way as anybody, I mean, all of you should be able, for example, in the case of STIs, to recognize the most common syndromes associated to STIs, vaginal discharge, urethral discharge, etc. I'm not going to follow because I'm seeing your faces. But, okay, but I think health literacy is something that we have been missing, and everybody should be empowered. I think we have to empower more the community. Technology can do that, and physicians need to learn to let it go a little bit. And so in the middle are the pharmacies that could be also a bridge and could help access to whatever is needed.